This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a continuing medical education podcast for healthcare providers. It's episode 80 for September 13th, 2022. We're calling this one Academic Bullying in the Medical Setting. I want to welcome all of you to the program. So we have another faculty development activity for you this week as we consider academic bullying in medicine. And it's actually a big problem with large numbers of medical providers from all walks of life and at all levels of training admitting that they have been the victims of academic bullying. And this can have a tremendous impact on individuals with consequences related to mental health, confidence, job satisfaction, and career advancement. But it also impacts institutions and patient care in numerous ways, which we will soon explore. We'll begin by defining academic bullying and give you some real-world examples of this toxic behavior. That way you can be on the lookout for it in others, but also inside yourself as we all strive for cooperation and civility in academic medicine. We'll look at typical characteristics of bullies, and we'll consider the characteristics of typical victims. We'll also consider strategic interventions aimed at reducing the incidence of academic bullying, and we'll let you know which of these strategies work and which ones are less likely to help out. Of course, in our usual PediaCast fashion, we have a terrific guest joining us in the studio. Dr. Maya Iyer is a pediatric emergency medicine physician at Nationwide Children's Hospital. She's also an associate professor of pediatrics at The Ohio State University College of Medicine, and she serves as the director of faculty development for the Division of Emergency Medicine at Nationwide Children's. She'll be here shortly, but first, let's run through our usual list of quick reminders. Don't forget, you can find this podcast wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode, and please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of the CME credit, it's really easy to claim yours. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. Again, it's episode 80. And you'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Of course, we offer credit to physicians, but also many other pediatric professionals, including nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. And since Nationwide Children's is jointly accredited by many professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you'll want to be sure the content of the episode matches your scope of practice, which in today's case really would cover everybody because we are all apt to be either victims ourselves or bullies or see it happen. And it's a good thing to be able to recognize it and to change the culture within your institution, regardless of where or what you practice within the field of medicine. Complete details on the CME and how to claim it are available over at the landing site, PediaCastCME.org. Also, we're on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And we do have that handy contact page over at PediaCastCME.org if you would like to suggest a future topic for the program. Also, I want to remind you the information presented in every episode of our podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Also, your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get Dr. Maya Iyer settled into the studio, and then we will be back to talk about academic bullying in the medical setting. That's coming up right after this. Dr. Maya Iyer is a pediatric emergency medicine physician at Nationwide Children's Hospital and an associate professor of pediatrics at The Ohio State University College of Medicine. Dr. Iyer holds a master's degree in medical education and has a passion for teaching and research, especially as they relate to faculty development, faculty affairs, maintenance of certification, and self-directed lifelong learning. She currently serves as Director of Emergency Medicine Faculty Development at Nationwide Children's and is the Associate Director for Women in Medicine and Science at Ohio State. Dr. Iyer also has an interest in the art of civility in academic medicine, which includes raising awareness and addressing the problem of academic bullying. That's what she's here to talk about today, academic bullying in the medical setting. But first, let's give a warm PediaCast welcome to our guest, Dr. Maya Iyer. Thank you so much for being here today.
Oh, thank you so much, Mike, for having me.
Yeah, really appreciate you stopping by. So let's just start with some definitions. What exactly is bullying and bullying behaviors? Like what constitutes, that behavior?
So there's many different terms that we use when we talk about mistreatment. We think about microaggressions, bias, discrimination, and all these terms mean different things to different people, so it can lead to confusion. But bullying, at its core, is a severe form of mistreatment. And its definition is that it's a conscious action of offenders who are abusing positions of authority, which means that there's a power differential, and they're intentionally targeting individuals through persistent negative behaviors. So that tells us it occurs over a period of time. And the reason they do that is to impede the target's professional growth, development, career, and education. So, like I said, it's a severe form of mistreatment, and given these power differentials, targets really have difficulty defending themselves. Yeah. And what makes bullying so challenging when it happens in the workplace is that unlike those terms I mentioned at the beginning, harassment and discrimination, bullying does not have a legal definition. And bullying does not necessarily cover individuals who fall under those of protected class, meaning race, gender, sex, etc. And so this leaves targets of bullying without legal recourse. And I think the second part, you asked me, what are these behaviors, correct?
Yeah.
Yeah. So bullying behaviors are exactly what we think about. As pediatricians, we think about bullying at school frequently, right? In training, we're taught how to manage, when your patients come in and they've been experiencing bullying. And oftentimes those behaviors that children in school experience are humiliation, shaming, being excluded. And all those same behaviors can occur in the workplace as well, too. But when you get into the work environment, there's other types of behaviors that also become prominent. And these behaviors include defamation of character, withholding of resources, constant criticism of work. There's a really nice instrument called the Negative Acts Questionnaire, which is a tool that has validity evidence and measures the frequency of these types of behaviors and if it rises to the level of which can be categorized as bullying. And it was developed by a group of researchers at the Bergen Bullying Institute, which is in Norway, and it's used worldwide, this tool. And this tool, the Negative Acts Questionnaire, has 22 different behaviors that could qualify as bullying, and many of them I've already described to you.
Yeah, so that sounds like it'd be a really helpful tool. We'll put a link to that. I think we could probably find it, put a link to it in the show notes so
Absolutely.
Folks can find that easily. So I did want to point out that bullying can sort of be on a continuum too, right? So there can be subtle things that just erode, a person's confidence and reputation and possibly the progress of their academic career, but they may not be overt, really out in the open, or they can be. So it's not always immediately apparent that bullying is going on, right?
Right. In the workplace setting, oftentimes when you get to the faculty level, and what the literature shows is that bullying occurs behind closed doors, right? It's not in the schoolyard where all these kids are gathering around and seeing a bully pick on a child. What happens are some of the behaviors that I mentioned that are included in that Negative Acts Questionnaire could include constant criticism of your work, or being given an unmanageable workload, or having resources withheld from you, not being included in crucial conversations or email chains. All those acts are, right? They could be subtle, but they qualify as bullying behavior, especially if they occur at a given frequency, which that tool is very helpful to decide.
Yeah. Absolutely. And we do also know, correct, that bullying is common in medicine. Like we have questionnaires of just general folks in academic medicine. A lot of people end up saying, yeah, I have experienced bullying in the past, right?
Yeah, that's true. So I will say that the nursing profession has done a great job of looking at bullying in their field. And the literature in the nursing world is rife with examples of bullying from nursing students to those in practice. When we look at bullying in academic medicine, we just don't have as much data or information or studies on this as they do. And what we've seen is that medical trainees, meaning students, residents, or fellows, the prevalence of bullying among these groups is 10 to 48%.
Wow.
So it's a wide range, right? When we look at faculty members, the data is really not there. So a year ago, my colleagues and I, Doctors Nancy Spector and Reshma Jagsi, who are world-renowned gender equity researchers, we conducted a really large study looking at faculty bullying among women physician leaders across the country. And in our group, we found that 85% experienced bullying. So across the medical education spectrum, bullying does occur.
Yeah.
Medical students, residents, fellows, faculty. And across the medical education spectrum, women physicians are more likely to be bullied than their male counterparts.
Yeah. Important to keep in mind.
Right.
The impact of bullying on the victim, and we're going to talk more about this, but it really, it affects someone completely, from their mental health to their professional interactions, career advancement, and even patient care, right?
Absolutely, Mike. And that's the really big crux of bullying. It has a significant impact on individuals. First, I will say bullying really can derail an academic medical career. This includes from being unable to obtain roles to being promoted, things at that level. But second, experiencing bullying, like you mentioned, has negative psychological effects. This ranges from decreased work productivity, emotional exhaustion, decreased concentration. The literature in Australia and the United Kingdom with the National Health Services has shown increased absenteeism with bullying. And then also anxiety, depression, PTSD. These psychological effects then in turn contribute to burnout. And burnout, which you've had on previous podcasts, can really be career-ending for individuals too. And also, when you experience that burnout in conjunction with bullying, targets of bullying are often in a situation where they feel like they have to change their role or their job or leave the institution where they've built their careers or even leave the workforce in general. So it causes a big attrition of individuals. And the problem with that, right, is that it's a serious brain drain on our profession as physicians. We have individuals who are leaving leadership positions or being excluded from organizational representation and withdrawing from the workforce. And this is causing medicine to lose the voice of really talented individuals. And this is particularly true for women and the impact of COVID on medicine, where we're seeing this great resignation and reshuffling. And this is happening just at the time when we're trying to diversify our workforce, right? And increase representation of all types of physicians. So
Yeah, absolutely. Bullying is related to harassment and discrimination. Those are other common words we hear where people are targeted. But they're a little bit different because, discrimination is based on personal characteristics or demographics, things like age, sex, gender. And of course, there can be legal recourse if you can show that someone is being discriminated against. And of course, harassment, if there's really verbal abuse, there may be legal recourse with that too. But bullying often is more subtle and a bit more difficult to define than harassment and discrimination, correct?
Absolutely. And like we discussed a little bit earlier, the individuals who are bullied do not necessarily fall under those protected classes. So it's really hard to address bullying in medicine. I did want to go back to your previous question for a second, because you asked me how does bullying affect individuals? And we talked very, very briefly about that. It does impact institutions and then also patient care too. So as we mentioned, as institutions, it really creates a decrease in workplace morale and creates a toxic workplace environment for people. And then they don't feel emotionally safe, right, in that environment. So you're losing a bunch of people in a leadership pipeline when workplace bullying is tolerated. But above all, it has a significant impact on patient care. And I think as physicians, this is the most important thing that we're here for, right, is to treat our patients and do a provide excellent patient care. So studies have shown that when doctors experience bullying, this can cause preventable adverse medical outcomes, medical errors, and then decrease patient satisfaction. So bullying really has an effect not beyond just the individual.
Yeah. You can imagine that from a patient care standpoint, that when a medical provider, whether they're a doctor or a nurse, sort of loses confidence in their ability, which can be one of the impacts of bullying, you start second guessing yourself and you start, wondering, am I providing the best care? And then you may start making decisions that aren't really in the best interest of the patient. You might be ordering more tests or less tests than you need to. And it really can impact how you practice medicine.
Absolutely.
Yeah. And then from a institution point of view, the reputation of that institution is also at stake, right?
No, that's an excellent point. It is. And as more and more public access surveys are becoming available and regarding the friendliness, which is often the umbrella it falls under of the workplace, that's a big thing that comes into play when people are looking for jobs.
Yeah, absolutely. It would seem to me, too, that the academic setting is sort of the perfect storm for bullying to occur. As you mentioned, there are power imbalances just naturally, just the way that we have our training of, brand new doctors, then we have attending doctors, we have residents and fellows, and then medical students down at the bottom. And so, and even within all the attendings, you have assistant professors, associate professors, full professors. So there really is a lot of power imbalances, as you had mentioned. There's also a very subjective criteria for recruitment and advancement. There are guidelines for advancement and guidelines for promotion, but they're not always exactly clear or they're left up to individual interpretation to such a degree that it's not really a checklist. It's a committee that has to debate whether you've made the checklist or not. And so because of that subjective nature, that also kind of allows there to be inappropriate actions. And then the departments are all siloed from one another. So we have pediatrics here and medicine over there. And so to have policies that are across the board can be sometimes difficult, and few checks and balances in place to address toxic behavior, right? It's all together there in medicine to allow this to happen.
Absolutely. We're very lucky, I would say, at both NCH and OSU in terms of our committees for promotion and tenure and being a pretty fair and transparent process, but that's not true at all institutions, as you mentioned. And there are numerous factors in that permit academic bullying. You mentioned this power differential, right? But part of the problem with the power differential is that when there's a power differential, that means that the bully for a certain target is often that person's superior, manager, someone higher up, right? They're in a position of authority. So reporting of bullying becomes really, really hard, right? And there's this very real fear of retaliation that really does occur. And there's a lot of literature shows that when an individual's bullied and does something about it, there's that fear of retaliation. And sometimes it makes it worse off for that target. And then the other issue is that reporting, as you mentioned, we have these silos, but it really even varies by institutions. Medical trainees are often protected under the policies of the Liaison Committee for Medical Education and the Accreditation Council for Graduate Medical Education, or the LCME and ACGME. And those policies do have statements that include the word faculty in them, but institutions don't necessarily interpret those policies as protecting faculty members. And so when that happens, really, where does an individual go to report it, right? Where do they go? Do they go to HR? Do they go to offices of equity? Do they go to DEI offices, ombuds people? It's really hard for individuals. So
yeah. And we're going to talk about some strategies that institutions can undertake in order to make a more fair process in just a minute. Before we get there, you were kind of alluding to loss of career opportunities, right? Mm-hmm. Not only from the bullying behavior itself, but also the fear of reporting it, that might cause issues, with future career growth. And so that's a barrier to reporting.
It's a large barrier. And that's what in our study of women physician leaders, we found that many people fear leaving their institutions because they feel like it can't be better necessarily, or it can, and they do leave. But there's this fear that if I report it, my already somewhat stalled career could probably be derailed completely instead. And so that's the big issue with that.
Yeah. So what are some of the characteristics then of bullies? And I know this data, this is actually evidence-based, and I am going to put in the show notes some links to some recent articles. And one of them is a meta-analysis, and this particular one was actually based on 31 studies that looked at the characteristics of bullies, so you can identify them in the medical setting. Who were some of the common bullies?
Yeah. So the study you're referring to is by Averbach and colleagues, and it was published in BMJ in 2021. And it's an excellent systematic review for anyone looking at bullying behaviors. But characteristics of bullying is often what I've talked about already, right? There are individuals who are often in power positions. So these are superiors, managers to the targets. So when we look at medical trainees, for example, we find that bullies for them are usually attending physicians, followed by senior residents, followed by nurses. And then when we look at faculty, we know that the bullies are individuals who are superior to the faculty members in terms of role or representation within the institution. So that power differential is very crucial in academic bullying to meet that definition, I should say.
Yeah. And you'd mentioned men are more likely to be bullies, and women are a little more likely to be the victims. I also saw that hospital administrators can be bullies to medical faculty.
Absolutely. Common example is problems with scheduling. We see that across the board in all different specialties. That type, or administrative responsibilities and being given an unmanageable workload. That's a common tactic that we see among those bully characteristics at those levels.
Yeah. And then I had also seen surgery, OBGYN, and internal medicine typically had more bullying compared to other specialties. Not to call them out, and certainly not everyone who's a surgeon or OBGYN is a bully. And I'm sure that there are bullies and victims within any of those, but that was just one where there was more instances of bullying behavior reported for those particular specialties.
Yeah, and it's within all those subspecialties of those major disciplines as well, too, across the board. And that pattern has been seen not just here in the United States, but again in the United Kingdom and Australia, where a lot of bullying research does take place.
And then what about the victims? Who are the typical victims of bullying?
Yeah, so I'm going to stop you for a second here. And I think what we should do is change the term that we use to describe victims. Instead, I would suggest using the word target instead.
Although the study used the word victims.
Yes.
To be transparent.
Yes, absolutely. And the reason I say that is that through my work, we have found that when anyone is labeled as a victim, that sends the message to peers, managers, supervisors that this individual is helpless, they're likely to be humiliated, and they're easily manipulated, and they can do nothing to change their situation. And so the term victim indirectly places the blame on the person being bullied who's at the receiving end of these actions, right? And on the other hand, the word target shows that the bully is the one exhibiting or demonstrating this egregious behavior. And there is, I have to say, when people are bullied, they often do feel helpless, like they can't do anything to change their situations. But we have to really be careful in the terminology we use to say that, it really is not the target's fault that this behavior is occurring. And the burden of the onus of changing this behavior should not fall on the target, right? It's part of this whole culture and milieu that we talked about where bullying is allowed.
That sounds like a letter to the editor of BMJ.
But you did ask for characteristics, let's say, of targets, right?
Yes,
so
yes.
we described women being more likely to be bullied than men across the medical education spectrum. And then targets also often hold skills and talents that the bully doesn't possess. So this makes the bully feel threatened. And so that is usually the reason individuals are targeted in academic medicine through several studies that we've seen at the faculty level.
Yeah. I found it interesting that there was more full professors felt that they were bullied compared to assistant professors. And I found that very interesting.
You know what? That is very interesting, but it's very true. And that's what our data showed similarly. The higher you go up into leadership positions, the more likely you are actually to be bullied. So the question is why? Why does that occur, right? Because the bullies at those levels are so high up, it's really hard to escape that behavior and change it. And who do you report to when they are the person you're supposed to report to these incidents, right?
Yeah.
So that is very true. true.
Yeah. So then you're more likely the bully is the chief of a department or a hospital administrator or someone who there's really not a lot of accountability for their behavior. And so then the people immediately under them tend to be the full professors. That makes sense.
So they're the big kahuna at whatever organization. And that's where it gets really, really tricky to address academic bullying.
Yeah, absolutely. I mean, you really need buy-in from the board of an institution to put policies into place to protect folks. I also saw that overweight folks tend to be targets more often, and also international graduates and non-citizens also. And that probably also then takes discrimination is probably a part of that, or in racism even, perhaps.
Absolutely. And we know those individuals with intersectional identities often experience bullying to a higher degree and more frequently than other individuals. So,
yeah. Another part of the article that I found really interesting was the factors that sort of allow this to happen, and I mentioned some of those in a broad category. But this next part was based on 35 different studies, and it really looked at what factors facilitate academic bullying and keep it from being addressed. Can you share some of those with us?
Yeah. The main thing I would say to take away from this part of it is that, and you touched on it before, is the hierarchical nature of medicine, right? We have people who are in positions and very meaningfully done so to facilitate education, but at some point, those hierarchies can result in abuse of authority, and that's what permits bullying. The other factor I would say that facilitates bullying in academic medicine is this phenomenon of toxic rock stars. I don't know if you've heard of that before, but
no.
Catherine Lucy, who was at Ohio State years ago, published this paper in Academic Medicine. I think it's in 2013. Don't quote me on that. But it describes this phenomenon of toxic rock stars. And these are individuals who bring value to an institution through grants generated, RVUs produced, our clinical reputation that they hold. And so sometimes unprofessional behavior from those individuals are overlooked because of these other talents. And so that's really interesting, right? And that's how bullies are retained sometimes in academic medicine. But the other issue is that when these individuals go from one institution to another, we're not solving the problem at all. And so Science published an article a couple years ago, and it essentially was titled "Stop Passing the Harasser," or "Stop Passing the Trash," as one of my mentors says. We really need to do a better job of institutions screening for that behavior on the hiring process too. And I will say the University of Virginia does an excellent job for that. And even the NIH, when they're looking at grants too, if bullying behaviors have been described by PIs, there's a reporting process in place, but they're also prevented in the future too. So
Yeah. I've also read that the reporting rates are pretty low, and there's a lot of factors that would go into someone feeling like they're being bullied but not reporting it. You had mentioned before that there could be fear that there would be an issue with, with academic advancement and with career development and all those things. What are some other reasons that people might be hesitant to report bullying?
Yeah, so people are very hesitant to report bullying, one, for the retaliation that they often face. But it's not just retaliation from the bully itself, but it's also the what they feel like they'll be viewed in the eyes of their peers. And so that's a risk that is up in the air for those individuals. And so that is one fear. And the other fear is that really it's not easy to report bullying in general, right? We don't have standardized anti-bullying policies that include faculty members across the country. So it's very hard for individuals to report at one institution to HR versus another institution to a professional committee and expect the similar outcome in those results.
Yeah. So it really is different from one institution to another. And as people move from one place to another, they felt very protected against bullying at one place, and you move to another one and suddenly that protection is not there. Or they may come to a place like here at Nationwide Children's where we do have mechanisms in place to address this, which is, fantastic. But there are a lot of reasons still why the reporting of bullying may not really take place.
Absolutely. Yeah.
So what can we do about this? What are some strategies and interventions that we can use to reduce the incidence of academic bullying?
This is the gem question to ask, right?
Yeah.
So bullying, as we've had in our discussion today, is really multifaceted, and it includes a lot of personal characteristics and personal relationship dynamics. So to address bullying, we really have to take a top-down approach with leadership support to develop a climate that prohibits bullying. Organizational leaders should develop and implement anti-bullying policies with statements on, for example, expected standards of behavior, education to raise awareness of bullying, and procedures to dealing with allegations of bullying and protection from retaliation. So it's often called zero tolerance, zero retaliation policies. And they should have tiered consequences within those policies. We often call those the 3 C's, which are conversation, consequences, and career, meaning when a bullying report is made, there's a nice chat, a nice conversation about these behaviors and how they're not permitted at this institution. And then if the bullying behavior persists, the next step is consequences, which could include, decreased protected time or increased clinical requirements, or it could also include delaying and promotion, for example, right? Tactics that bullies unfortunately use. And then finally, the last thing is career. And so this is where leaders really, when they're committed, they say, if this doesn't stop, you're terminated,
Yeah.
So
it would seem to me too that if you had some researchers at an institution who were really looking into this and publishing and making this part of their academic career to identify bullying and try to make the culture better across the country as sort of a national leader, and so someone like yourself being here at Ohio State and Nationwide Children's Hospital, who's a really advocate for identifying bullying when it occurs, making sure people feel comfortable reporting it, but then also doing our best to support the bully to get out of that toxic pattern of behavior. Because at the end of the day, if they have special skills and that's why they're at an institution, they just happen to be a bully, and they're, nothing is happening because of those special skills. I mean, we want to make the culture as great and supportive and inclusive as we can, right?
Absolutely. And in my research, we found that many people don't realize that they're being bullies too. And so this tiered level of consequences gives an ability or permits for faculty development, right, of individuals. That being said, I think with the top-down approach, oftentimes it's really beneficial to have committees dedicated to investigating reports of bullying and providing mediation. These committees should think of bullying or every instance of mistreatment as a possible and potentially preventable incident instead, rather than thinking of it like an unmanageable problem, which we often see in reports from HR in the literature. But also, we need to not just take this top-down approach, but we need to take a bottoms-up approach, right?
Yeah.
We need to have faculty development. It should extend beyond our traditional bias training and DEI initiatives, and really should specifically address bullying. We need faculty development on understanding targets' rights and methods for how do you report at your institution, should a policy exist or not exist, right? And fostering upstander skills that allow targets and those who witness bullying to actually call out bullying in the moment, right? So we want people to move from being a bystander, not doing anything when they witness that, to being an upstander and seeing something and saying something.
Yeah.
And this could include even being an upstander includes reporting the event or helping the target thereafter and providing support. So both this top-down and bottoms-up approach is needed to really, address bullying at the institutional level.
Yeah. Some of the specific ideas that were put forth in the article, and then it was interesting because they took some of those ideas and then examined how they work in the real world and whether they did what they were designed to do or not. So I'm just going to run through a few of these. One was just workshops with vignettes to improve the recognition of bullying. And that actually was shown to improve at least the recognition of it. Maybe it didn't stop it from happening, but it just, as with anything, the more you talk about it, the more awareness, and then the more you're going to be able to recognize when it does happen, whether you're witnessing it or being a part of it from either side, whether you're the bully or the target. Another one was actually to form gender and power abuse committees that establishes mechanisms and workshops and puts policy into place. And for that one, when there was a gender equity office, 96% of formal reports were resolved. Now, that doesn't mean that, every instance got reported, but when it did get reported, at least there was a mechanism in place when you had an equity office that would help to sort through and deal with the problem. There's also professionalism in contracts. So like as soon as you onboard, this is like we're saying, hey, professionalism is a part of our culture. This is how we define bullying. And if this occurs, then this is how it's going to be handled through, a professional committee. And there may be remediation and, all of those things. But if you put that in the contract right from the beginning, that can be helpful, right?
Absolutely. And these are all great ways to address bullying at different levels, right? In academic medicine.
Yeah. Mm-hmm. Now, the one-off retreats. So,
yes.
Workshops to improve recognition. Okay, fine. So you think, okay, we're going to have a anti-bullying retreat and make everyone, be able to see it and not do it anymore. and that does not work so much, right? You really need smaller ongoing efforts than like one big retreat.
Absolutely. I often say it's like the sign on the wall, right? Reminding you to hand wash, you stop looking at that or you ignore that it's in the room. So yeah, the one-off retreats aren't necessarily helpful in recognizing bullying or doing something when it occurs. There's actually not much data out there in terms of effectiveness, right? And causation. If these events cause decreased incidences or increased reporting, there's more of an association between them. But these are future steps, and these are great first steps. And, this is a great area for future research to see what we can do.
Sure. We just have to, from an anecdotal standpoint, just have to remember that when we're exposed to teaching of some kind, it may change our behavior for, a month, and then you kind of fall back into your previous patterns. And so that's why you really do need to keep talking about it. Just like we do with equity and racism and discrimination and harassment and bullying. I mean, we have to keep these items at the forefront, not only for our own professional satisfaction, but for the reputation of our institutions and for patient care and outcomes.
Absolutely. Yes.
Yeah. So as we think about an organization that sort of is an umbrella over the entire medical field, whether you're in medicine or pediatrics or OBGYN or surgery, the American Medical Association or the AMA kind of has a big voice for all of medicine. How have they responded to bullying in the medical setting? Is it a priority for them?
So this is it's a good point that we're talking about this. So in 2021, the AMA adopted policy 515.951, which was bullying in the practice of medicine. And what it was aimed to do is to prevent bullying in academic medicine, like the title says. And to my knowledge, that this is the first policy put out by a governing medical body that specifically calls out bullying, its consequences, and that institutions really should take action at this point. And the nice thing about this policy is it gives you criteria for what you should include should your institution develop an anti-bullying policy. And it's 7 to 8 different steps and criteria that should be included.
Yeah. And one of those was at the medical school level that there should be some anti-bullying policies put into place. So how are U.S. medical schools doing with following the advice of the American Medical Association?
Yeah. So this is really timely that you've brought this up. So my colleagues and I just conducted a study, and it was published last month in JAMA Network Open, looking at the comprehensiveness and availability of anti-bullying policies at medical schools across the United States, specifically at the faculty level. And we looked at schools in the U.S. News and World Report rankings from both primary care and research, and then a random sample of schools. And when we sampled, our sample consisted essentially of 91 schools that spanned all types of rankings, all types of specialties that they were prominent for. And we found that when we looked at those 91 schools, we only found 4 had anti-bullying policies. Wow. Yeah. And then we did find that a lot of schools had anti-harassment policies, right? We think about sexual harassment when we talk about harassment, but harassment is also a broad term that encompasses a lot. And so when we looked at anti-harassment policies, 60 schools did have anti-harassment policies, but only 10 included bullying in those when you break it down. And why do we need to break it down? Because remember, as we said before, bullying is not protected under other policies that protect a protected class, which is a lot of protection words that I'm using, but that's, the legal definition.
Yeah. Yeah, absolutely.
Yeah.
So really what we're after is a bullying specific policy so that when bullying occurs, we can say, hey, here's the policy, as opposed to it just being mentioned in a harassment policy.
Exactly.
You really want bullying addressed specifically because that's going to give more teeth to being able to get rid of it in the culture and improve things.
Right. And so part of the AMA's criteria was if you have a policy, right, you need to include faculty members, you need to have your institution's mission statement with a commitment to eradicating bullying, defining bullying and unprofessional behaviors, and then discussing the roles, right, of employees, faculty, staff, and outlining what steps one should take if they experience bullying. How do you confidentially report it, right? You can never really provide anonymity in these cases, unfortunately, but confidentiality should be provided, and prohibiting retaliation as well. And so when you look at this comprehensiveness, that's a great, setup to give good anti-bullying policies. In our study, we actually found none of those 4 schools had met these comprehensive criteria. And so I will say kudos to them for, really taking the charge and addressing that, but there's still work to be done.
Yeah, yeah, absolutely. I want to call out the 4 medical schools.
Sure,
I think
absolutely.
I think they deserve some kudos. Even though their policies aren't as robust as would be suggested from the American Medical Association, that they're at least a start. And those are the University of California at Davis, University of Colorado, University of Wisconsin-Madison, and Pikeville College of Osteopathic Medicine in Kentucky. And so those are the 4 that actually have anti-bullying policies in place. You'll notice Ohio State was not one of those mentioned. Have you talked to the dean to see if this is something we should be addressing?
So I have talked to the dean, vice dean of faculty affairs for this. And we do have a policy on professionalism and mistreatment, but again, it doesn't specifically call out bullying, so it would have fallen out from our sampling strategy. Yeah. Yes, and they're very well aware of that at the College of Medicine. I will say NCH does call out bullying and is specific on our policy here at NCH. So yes.
Oh, very nice. Yeah, tell us about that.
Yeah, so anyone can access the policy on Anchor if you type in bullying, and it comes up and it tells you how to confidentially report, where to go to for bullying if you've experienced it, et cetera. So we do have a pretty robust method. It doesn't meet all those criteria, unfortunately, again. But again, NCH wasn't included because we itself is a freestanding children's hospital or not a medical school. So
that makes sense. And I'm reassured by the fact that we do have policies in place here at Nationwide Children's. And the goal with those policies really, the ideal goal is to improve bullies' behavior and to make it a better workplace for everybody. Not necessarily to be punitive. It may come to the point where someone is doing it so often and really, doesn't care about their targets and, they do need to be let go. But at the end of the day, we really want to see people's behavior change and to make the work culture better for everyone.
Absolutely. Right. We want to create an environment that is civil and fosters collaboration, growth, et cetera, where everyone can thrive. So we want to address bullying behaviors, but we also want to provide support and a way for targets to actually feel that, they can do something and it will be taken seriously.
Yeah, absolutely. One other episode that we had not too long ago, I feel like really is part 2 of this one, even though we did that one first, because this idea of emotional intelligence in both clinical and academic medicine, which we covered in PediaCast CME episode 74, really is important, especially if we want to change the behavior of bullies. Because often they don't, as you mentioned, a lot of times bullies don't realize that they're being bullies. And so we really want to improve our personal awareness of the behaviors that we have and how we engage and interact with our colleagues, with trainees, with administration, with patients. And so once we become aware of our behaviors, then we can start managing our behaviors. And so this episode that we did with Erica Banta from Ohio State, we talked about emotional intelligence and personal awareness, how to manage your own behaviors. And then the next step with that is a social awareness, being able to read the room, being able to understand, what the power differentials are that exist within your sphere of influence within the institution, and then managing relationships, in an appropriate way that takes empathy into account, that takes, maybe someone needs a little help. And so it's easy to start bullying that person. But if you put yourself in their shoes to see what barriers and challenges they have that maybe you don't have. And so, sure, it was easy for you, but maybe it's not as easy for them. And instead of bullying them, if you would come along and support them because you have empathy for what their life is like, that can make a big difference. And so I would encourage folks that really, I think should be required listening personally, but if you really want to learn more about emotional intelligence, check out that episode, which again covers personal awareness, self-management, social awareness, and relationship management. Because I feel like if we all put those ideals into practice, there would be a lot less bullying and a lot more civil culture within medicine. Would you agree with that?
I would definitely agree, Mike, with that.
I'm on my soapbox now.
Yeah, you're allowed to be. We have given a lot of national workshops and international workshops on bullying, and we talk about what do you do if you're the bully yourself, right? And it's exactly this EQ issue you're describing, and understanding the difference between your intent and impact, and above all, learning to apologize, right? And so I feel many of us have been bullies and we didn't realize it.
Yeah.
And
yeah.
so
yeah, absolutely.
Even with our well intentions, right? So.
Yeah. And, it's cathartic to say I was wrong. There's something about that. And I was, some people are going to love this and some people are going to seriously roll their eyes. The most recent season of Big Brother, there was an example of someone who, they were making comments that were racist at their core, who really I don't think understood that they were making those comments. And then once the light bulb went off in his head that what I was saying wasn't right, he was so apologetic. And so you could just see learning happen. Did you watch this or no?
I did not watch it, but I've heard about it.
Okay.
Actually, so.
Yeah. So it was kind of amazing to watch, to see someone who maybe had not been exposed to other cultures and other races and the comments that were made, and then to see him really grow in that. So I don't know. I went off on a big tangent here, but it seemed kind of related,
It's what you said, right? We're here to continue to grow, and, we're always learning. That learning is lifelong. And so to have that personal and professional development is really critical to our continued growth and, becoming better doctors for our patients.
Yeah. Hopefully you don't have to do it on national TV, on a national stage, just to do it in your department. Practice emotional intelligence, and please don't bully people. All right. Well, we appreciate you stopping by so very much. And we're going to have some great links in the show notes, definitely to the articles that we have mentioned in BMJ and JAMA Network. We'll also put a link to that PediaCast CME 74, Emotional Intelligence in Clinical and Academic Medicine. And then that tool that you had talked about. What's the name of it again?
It's called the Negative X Questionnaire.
Okay. And that can help us identify bullying behavior in the medical setting. And we'll put a link to that in the show notes as well. So in the meantime, Dr. Maya Iyer with Pediatric Emergency Medicine at Nationwide Children's Hospital, thank you so much for stopping by today.
Oh, thank you so much. The pleasure is mine.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to our guest this week, Dr. Maya Iyer with Pediatric Emergency Medicine at Nationwide Children's Hospital. Don't forget, you can find PediaCast CME wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. Our landing site is PediaCastCME.org. You will find our entire archive of past programs there. along with our show notes for each of the episodes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a future topic for the program. Reviews are helpful wherever you get your podcasts. We always appreciate when you share your thoughts about the show. And we love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. So you've listened to the podcast. Now be sure to claim your free Category 1 continuing medical education credit. It's an easy thing to do. Simply head over to the show notes for this episode, again, episode 80 at PediaCastCME.org. You'll find a link to the post-test in the show notes. Follow that link to Cloud CME, take and pass the post-test, and the Category 1 credit is yours. Super easy, right? And again, we offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. Of course, again, you want to make sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. Also want to remind you, we have an evidence-based podcast for moms and dads, plain PediaCast without the CME. Lots of pediatricians and other providers tune in as we cover pediatric news, answer listener questions, and interview pediatric and parenting experts. Shows are available at the landing site for that podcast, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by, and until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.